Hello, good morning all. Myself, Dr. Birut Patel. I am a professor in the Department of Prosthodontics, Narsibhai Patel Dental College, Sakarchand Patel University, Visnagar. Today we'll be talking about relining and rebasing in complete dentures. Okay? So students, many of time what happens, when we deliver our prosthesis, many of time because of the processing errors or because of the immediate denture, after some time there is a ridge resorption happens. So because of that there is a loosening of complete denture or shortening of the complete over extended over denture. So in that cases we have to correct the denture base as well as the borders or the loosening of the denture. So coming to the definition, it is defined as a procedure used to resurface the tissue side of the removable dental processes with the new base material, thus producing an accurate adaptation to the denture foundation area. Rebasing, the laboratory process of the replacing the entire denture base area on the existing prosthesis. So here relining, we only renew the borders area and increase the retention and stability, whereas rebasing we remove whole base pink prosthesis and we keep the artificial teeth as it is. So when we do the relining rebasing, in the loss of retention and stability, loss of vertical dimension of the occlusion, loss of support for the facial tissue, and reorientation of the occlusal plate. Minimal to moderate changes require the relining indicated, and moderate to maximum changes rebasing is required. So immediate denture, when it is indicated? It is indicated after the when we have given immediate dentures after 3 to 6 months, so that what happened, because of this immediate extraction and immediate denture fabrication, there are chances that the residual ridge resorption happens, so that after the time varies 1 to 3 months or the 6 months, the ridge resorb and there is a space created between the denture base and the alveolar ridge, so that causes the loosening of the denture. When the ridge have resorbed and adaptation of the denture to the ridge is poor, and when construction of the new denture is not possible, such as the chronically ill patient, but in that cases the tooth surfaces or the artificial tooth has to be in a good condition. Contraindication, when excessive amount of the resorption has occurred, when the abused soft tissue is present, if the denture has poor aesthetics or the unsatisfactory jaw relationship, if the denture creates a major speech problem, okay, and if this severely osseous undercut exists, surgical correction has to be done before doing the relining and rebasing. So what are the general consideration? Or occlusal vertical dimension should be satisfactory. So the existing denture must have the centric and vertical relation should be in a good condition or the correct position. Centric occlusion should be coincide with the centric relation. Patient appearance should be satisfactory. Oral tissue should be in optimal health. Prior limitation of the both the dentures should be correct. Denture base extension are adequate. Interocclusal distance is correct. Speech is satisfactory with the existing tooth teeth arrangement, and the denture base extension ensures that the ensure distribution of the masticative forces over the large area as possible. So coming to the general factor to be considered before relining and rebasing is the acceptable vertical dimension and the centric relation as the aesthetics. So the previous denture which we are going to relining rebasing, it has to be in a good condition. So for relining and rebasing, we require the impression of the underlying tissue. For that we have three types of impression techniques: static impression, open mouth and closed mouth, functional impression, and chair side check technique. Here static impression and functional impression, where impression is made and the denture is processed in left side, whereas the chair side relining, in this, the relining is done at the clinical setup. The static impression technique, there are two major variations of this static impression technique. One variation, the denture the old denture is used as a tray, and either the existing centric occlusion is used to seat the denture within the lining procedure material, or else the centric relation is recorded. So open mouth technique, it is described by the Boucher in 1973 in method of relining both maxillary and mandibular at the same appointment. The dentures are being used as a tray for making new impression. Existing centric occlusion is not utilized and new record is made after the impressions are made. So centric relation, the jaw relation recorded using both the dentures as a recording base. Then denture preparation, 1 mm space is provided inside the denture for new impression material and border shortened for the new impression. Border molding is done using the green stick compound or the putty impression material specially made for the border molding. Then impression is used using zinc oxide eugenol or rubber based light body material. Then occlusal refitment is checked and follow up and of the denture. Advantage of the open mouth technique, where loss of vertical dimension can be compensated using during the relining procedure. So here what happened, relining and rebasing, the vertical dimension can be re-verified or established before the impression, and the errors in centric occlusion reduced during the left stages. Disadvantage, time consuming procedure for establishing the vertical occlusion dimension is highly questionable. Now closed mouth technique, in this technique each denture is used as an impression tray and the denture occlusion is used as a stabilize the denture and while making the impression. So as usual, centric relation is established or centric relation is checked before the impression. Denture preparation is done. As usual, the borders are trimmed 2 mm or the 1.5 to 2 mm, and the intaglio surface is also trimmed according to the denture's needs. Impression procedure as usual, border molding and the final impression made using ZOE or the light body impression material. And then after that it is lab procedure, it is sent for the lab procedure, and after the converting and the adjustment in the denture base or the relining, then the occlusal re-verification and the follow-up is done. So chair side relining technique, several attempts have been to discover the material that can be added to the denture base and allowed to set in the patient's mouth to produce an instant chair side relining. They have met with the failure following the reason the material produced a chemical burn in the mucosa, color stability was poor, the resulted in incorrect vertical dimension, and results were often porous and hence develop a bad odor. So this is the chair side relining technique. It is usually used for the softly lining, temporary softly lining material for the time being, or the tissue conditioning method. Now coming to the lab procedure, how we proceed for the lab procedure. The process of the replacing the impression material with the acrylic resin is the same for the static and functional approach. Main difference is relining and rebasing is that the rebasing require the entire denture base area has to be removed and only the existing teeth set is used but the denture base is replaced. There are three methods: flask method, articulator method and jig method. Here the denture is trimmed along the borders and occlusal jig is made. Then after impression, the flask method, the cast is poured onto the impression, then the denture is flashed again as we do in a denture processing, regular denture processing. But after deflasking, the intaglio surface, the impression material is removed and the borders are trimmed again satisfactorily, and the regular processing method, what we do in a heat cure denture based resin, we do and process. The denture is retrieved. Second is articulator method. In this, this is in which the lower articulator member it is poured with the plaster, and over that the impression or the denture occlusal table is made, so that the reorientation of the denture can be done. So after that, there is a, you can see there is an indentation onto the plaster slab, and on that it is called as index. On that, what we do the next, we trim the extra areas of all the plaster denture and reorient our existing occlusal plane onto the index, and it is placed, means the articulator is closed over. And then what we do, we spread the mist acrylic onto the areas, impression area, and we retrieve our denture. Jig method is same as the articulator method, whereas here instead of the articulator, jig is used, where the jig are placed onto the onto the processing areas. And it is processed as the articulator method. Now, insertion and recall method. The insertion process and the rechecking and the maintenance is as same as the what we do into the our regular denture procedure. Thank you. So class, what we have seen is relining and rebasing method. So relining and rebasing, there are hard acrylic relining rebasing and the soft relining and rebasing. So usually soft liner is used for the tissue conditioning whenever there is a ulceration or the tissue abuse or the tissue conditioning is required. In that cases, or the undercut is there, in that cases we go for the soft relining method. And hard relining method we do the, in a cases where the retention and stability is compromised. Thank you. Have a nice day.